Uh, I'm Charan Dasagrandhi. Welcome to Uwatcha channel. Today we have with us Dr. Praveen from UK. He'll be discussing with us on the current COVID situation and help us understand, better on how to be aware of the situation and how to handle this on various aspects of COVID. So Dr. Praveen, he's a hematology consultant at Royal Wolverhampton NHS Trust, and he did his medicine from Royal College of Medicine. Sir, can you please explain a little bit on about your professional career?
Okay, so as I said, I'm a physician basically. I worked many years in India before relocating here. Then I further subspecialized in hematological malignancies and bone marrow transplant. So currently I'm working more on the blood-related problems. So why I got attracted is because we deal with viral infections very commonly in our immunocompromised patients. So practically we have dealt almost all the spectrum of viral diseases. So when this came, naturally, I got sort of interested, and being myself severely affected in the very beginning of the pandemic. So I wanted to learn more. So since then, so I've been updating myself, speaking to a lot of national experts, international experts. So this has given more insight and hope to share some of them with you today.
Yeah, thank you, sir. We'll start the interview, sir. I've seen that close to nearly 1.7 million people have died in India so far due to COVID or coronavirus, and more than 300 doctors and healthcare staff died due to this virus. Of course, it's very unfortunate that the healthcare staff, these people, healthcare staff are dying. So the big question is, what are the responsible reasons for these deaths? I mean, what are the reasons that resulted in this case, in this situation, sir?
Okay. So let me first update you the most recent figures. The last figures I got was 515 doctors have died in India. This figure was furnished by the Indian Medical Association. So if you take all the healthcare workers, which includes nurses, paramedical staff, I think number will easily be anywhere of 800 to 1,000. And considering that we don't have all the records of all the allied doctors working in Ayurveda, homeopathy, we don't know, the number may be high. Now coming to your question, why there is a higher death rate of doctors in India. In fact, India has got the highest number of doctors' deaths in the whole world. There is a recent write-up in Lancet about doctors dying in Mexico. I mean, they have something like 140 plus ticking on. But we are talking something like 515 doctors, and every day there is a news comes, 2 or 3 doctors are dying, and most of them they are in middle age and with young families. So obviously, this is a very pertinent question that everybody should ask, because they themselves being a true warriors, and we are losing them. It's like losing every soldier from the battlefield, how it wreaks havoc. So the same thing is happening. Now, when the pandemic hit India in March, there was a lot of information that was coming through from the Italian doctors. They're the ones who first told the whole world, saying that, look, this is not like a flu, it is a very bad disease. Watch out, guys, it's very difficult. And it looks like their warning was not heeded. The neighboring countries didn't listen, and then subsequently America got affected. And then India went down for a lockdown, and then they released in May first week. Till then, the impact was not at all known. It was like a cocoon. So there was a sense of over optimism, thinking that it will not going to cause much of a problem. And a lot of theories were floating around that immunity is better, so therefore we are sort of protected. And the Indian Medical Council issued this directive to all the healthcare professionals to go on the hydroxychloroquine prophylaxis. So that came very early on, and following which almost every other neighboring country, be Pakistan or Sri Lanka, they started scrambling to get hydroxychloroquine tablets in the black market. And literally every doctor went on this prophylaxis. And when this was issued, I really sort of get perplexed where this data is coming through. And they quoted only one single line sentence saying that in SARS-CoV-1 in 2003, apparently hydroxychloroquine was sensitive, or rather virus was sensitive for the hydroxychloroquine. And I mean, it was early on, so nobody knew. So everybody went on this prophylaxis. And there are some warning shots coming through some certain quarters saying, look, it is not entirely safe. You need to have ECG monitoring to see if there is got any rhythm disturbances. And there was this careless attitude that came, look, we are given to millions of people on malaria prophylaxis. We have got more information than any other country, so it's entirely safe. And many of the doctors I know, they started taking this prophylaxis, and I was the one who sort of vociferously was against this, because there's hardly any data. I mean, what you have demonstrated in vitro doesn't translate into when it goes inside the body. And also, there are scientific aspects that are associated. What is the dosage that is required? What is the level of the drug that is required in the blood to inhibit? And so many things, so many questions are answered. But ICMR issued this guideline, and they stuck to it. And what health professionals needed or even now need is effective PPE protection. That's all it is. I mean, the mask and what you're wearing. And early on, India had a lot of shortage of these PPE kits. Of course, later on, the Ministry of Textiles sort of rallied and then got all the textile industry to manufacture, and we have in fact started exporting. That's a good thing. But early on, I know that my colleagues working in government hospitals in India, they were crying literally. They were using very substandard PPEs, and I still don't know how it is the situation in the tier 2 and smaller towns regarding the PPE availability. There may be an issue. And the second aspect is, when a pandemic like this strikes, when the doctors are exposed, you should always risk assess in terms of your suitability to the role. What happened was 60 and above age doctors, they all sort of self-quarantined themselves, having known that doctors elsewhere were dying. So the onus started falling on the middle-aged doctors to be pressed into the service. So irrespective of whether you're an ENT surgeon or an ophthalmologist or an obstetrician, they were all pressed into service, and not enough staff were there in the ground to keep doing the work. So people were naturally forced to work for long hours of shifts, 12 hours. Many of them, they kept saying that, but they had no medium to sort of highlight what is going on. So they were made to work continuously, no gaps given. So they were exposed to high viral threshold. Viral exposure was high, not inadequate break times. So they were very well exposed compared to the rest of the part of the world. And I suspect this has played also a major role. And the facilities where the COVID patients had to be cared in the beginning was supposed to be in the COVID only designated hospital, which was mainly in the government hospitals. So the doctors there, they don't deal with this sort of a complicated respiratory viruses and other things routinely. So they were constantly put into the service, and I always wondered who made this unscientific proposal. Of course, later on when the government realized that there are not many beds, so they started enrolling all these private hospitals and even the small center hospitals. Many of them, they lack any facilities to ensure adequate physical distancing and safety working space for the doctors and the nurses to work. Small dingy rooms, poorly ventilated rooms. These are the kind of setup you see more often in the government hospitals. And I know those sort of environment will be definitely counterproductive, and it is very dangerous. So many of these factors have gone into play why we are losing many doctors, unfortunately. And despite the hydroxychloroquine being debunked by most of these studies that's come through, and for strange reason, the ICMR has still kept this hydroxychloroquine prophylaxis in their algorithm. I don't know why there is this overindulgence in this drug, which has practically been shown not to have any clear benefit. Of course, we are waiting for more data on the prophylaxis in healthcare professionals, but whatever even the studies that are coming through, they are indicating they're not useful. So they should have moved on in course of time. You should move on, and this is an evolving situation. Science somehow lagged behind in India. They should have revised the protocols and ensured the safety of the doctors, which has not happened. Even the official body, the Indian Medical Association, they should have represented the doctors' interests. I mean, you will be surprised that doctors, when they fall ill, they don't have any means to get to bed for themselves. A couple of my colleagues, they became unwell, they deteriorated within short period of time. And I know how a couple of my friends, we rallied together, ringing every little small hospital to find a bed. Even today, the situation is the same. Just day before yesterday, one of the doctors in Bangalore succumbed. Unfortunately, he was a surgeon, and apparently he was jumping one hospital another trying to get a bed. So can you imagine that this is the treatment that is being meted out to the doctors who are risking their own lives, but when they fall ill, there are no beds reserved for them. Government should have ensured, at least for the healthcare professionals, some beds being reserved so that those beds are not used for general public. I mean, this is a simple thing they could have done. They have not done that. And one or two instances in the last 1 week, what I've heard is people didn't get remdesivir within the short period of admission. These are the doctors I'm talking. It's a shame that you're not looking after your own doctors. So that is the first realization that has to come. And there are many people who are collecting the data on the doctors' deaths. We still don't know how many of them had comorbidities. But I suspect, going by the general trend of the general health and well-being of the doctors in India, I'm not surprised that many will have had many comorbidities. Historically, there is a problem with the physical and the mental well-being of the doctors in India. The life insurance of India, they did a study a few years ago. When they said that average life expectancy is 59 years, when I shared in some forum, people couldn't believe it. I mean, can you imagine the doctors who are supposed to be advocating health for others, they themselves are succumbing prematurely. A lot of other factors. I mean, comorbidities are high, long hours of work, mental stress is also equally high. So the overall fitness is also not very good, and you're exposing suddenly to this killer virus. So unfortunately, it is taking a heavy toll.
Yes, true, sir. Definitely. Also, I've observed, like in many of the places in India, the spread of this virus happened, because of doctors, because they themselves, got affected and in serving people, and rapid rise of COVID-19, happened even because of some doctors. This is what I observed.
Yeah, I mean, early on, I think there are instances of
Yes.
a few doctors were spreading it, but I think probably with more education, I think they are also sort of exercising adequate precaution. But I'd still go back to the working environment where they are working with 100 people, just thronging a little small dingy clinic outpatient with practically everybody breathing over the other person. And can you imagine the doctor being, working for 6 hours at a stretch, seeing those patients? He will carry not only the virus, and he's going to go and spread it to his family members also. So, there is a saying, I think Indian Medical Association, in one of the letters they wrote, this nice analogy that in a war field, the soldiers get fired and the bullet kills them. But here, these soldiers, so-called doctors, they are getting not only fired, but they're taking the same bullets back to their family, and the family are also getting hit. So you got two, people getting affected. So this has to be taken very seriously.
True, sir. Definitely, sir. Because I have observed in many of the places in India this particular situation. Also, like I feel that done like public, even doctors were not well educated about the signature of this, like how this virus behaves, and how exactly we have to treat this virus. I think not many, at least in the initial stages, doctors were not well informed and well educated on this particular virus. I think this lack of education can also be one of the factors, for the spread of the virus, or doctors unable to treat it properly, or rapid rise in numbers. So what is your stand on that?
So because how the Indian healthcare system operates with large large population of general practitioners. These are or maybe registered medical practitioners or allied specialties, Ayush doctors, or the MBBS doctors, are the first port of call. Even today, in tier 2 and smaller towns, people go there, they present with whether they've got a cough or a cold, they go to these doctors. And generally, this segment of the doctors, even though they sort of cover a large population, they are not included in sort of ongoing education and professional development. They are left out. These are like isolated clinics they run, and they seem to have been practicing for many years. Like if somebody comes, prescribe a steroid, give some inhalers, give some antibiotics. That seems to be a cocktail, which is probably would have worked earlier on, but this disease is a different one. So it has worked as a double-edged sword on both sides. Now they had no clue how to treat this. So they were much more exposed, and the higher mortality is now proven to be among the general practitioners also. And also the delay in diagnosis and triaging them to a facility to get the earliest treatment through these ones is also a bit of a challenge. Nevertheless, we should thank these unsung heroes who, many of them, I think genuinely they have worked in areas where you don't have any decent facilities. These people have at least suggested it could be a COVID. Why don't you go to some facility and arrange that? So at least we should be thankful that there is some skillful staff that India could manage in those remote areas. I think the Indian Medical Association, the Association of Pediatrics, and all those things, they have been doing these regular webinars and ongoing sort of educational events, and I don't know what's the reach of that, but I think the efforts have certainly gone in. At least in major cities, doctors do know the treatment algorithm, at least what should be done in early on and in later stages.
Yes, sir. True. Also, like I have seen that especially with respect to the guidelines which issued by WHO and ICMR, I'm sure these these wrong guidelines has truly misguided many countries, as well as India is one of the victim of that. Like I mean, of course, people don't, even these organizations don't admit that this, but aren't these institutions a great threat when you start propagating wrong guidelines, and this sort of situation happens, and I don't see even government coming forward and admitting that. So like what about this wrong guidelines, like what is the status of understanding these organizations have, like WHO or ICMR, like how they misguided people and the entire country in this situation, sir? Wrong guidelines. I'm sorry to interrupt you. Not only that, if you take the recently one, the plasma therapy, which people have been speaking that it's not valid. Recently, ICMR declared it, and even if you take the vaccine, like the drugs like remdesivir or favipiravir drugs, antiviral drugs which are being given, they don't have valid license, and even still be it government or be it ICMR or any authority body doesn't come forward. And I've observed that like these drugs which are not approved being given to people are one of the prime reasons for many deaths in India.
See, this disease is sort of evolved in the last 6 months. So initially there is hardly any information that was available. So whatever the initial guidelines that came through, I think they very much incorporated what was little known about this. And so, we can't criticize the earlier guidelines that was there, but at least later on, when the randomized controlled trials started coming and showing, for example, hydroxychloroquine, no benefit, there's no reason for ICMR to sort of include, and I believe even today they have the same thing continued on. And also the inconsistency of approving the drugs. You mentioned about favipiravir. I mean, I was surprised. I mean, I started looking at the literature, and there is only one Chinese paper in one of the technology journals, not even a biomedical journal, just involving about 80 patients. And this is a drug which the Japanese Fujifilm developed for severe influenza. But not many people used, including Japan. It was developed somewhere in 2014, and not many countries have used because there are some concern regarding the teratogenicity. So when you have such a drug, you need some robust data, to sort of approve. And I was surprised that the India approved, and practically now everybody is getting this favipiravir, and I don't know where the data comes from and what is the utility of that. I don't know. Same thing holds good for other drugs like itolizumab, developed by one of the company in India. They had practically no data at all. When asked, I think you got all evasive replies that you go and ask the customer, that is the patients who are satisfied here. I mean, this is a science where you cannot go with the hearsays. You need a solid data, and it is the efficacy as well as the safety that is more important. Of course, this is a desperate situation where people are trying to find different avenues to target this virus. But at the end of the day, you need to have clear three things. One is the risk-benefit ratio, and second is the safety, and the third one is efficacy. If you're not able to demonstrate this, then don't approve it. And this is what largely that's been followed all over the world. And I'm particularly critical about this favipiravir and itolizumab that came through. Now, subsequent amendment to the guidelines issued from the All India Institute of Medical Sciences through the COVID task force, I think largely they have taken into consideration the wisdom that has evolved. I think I just saw one of the most recent ones. I think pretty much they have indicated when to give the remdesivir, that should be given early on and not when they landed in a ventilator, and dexamethasone, and so on and so forth. So I think pretty much they have revised the guidelines, but how much it is being followed across the country, that I don't know. It's up to the individual doctors to get sort of acquainted with the rapidly changing scenario and practice what is best in the circumstances. Now, in terms of the WHO, there are a lot of inconsistencies right from the time delay in sort of declaring this being a pandemic to sort of airborne transmission, human-to-human transmission. So there are a lot of inconsistencies that WHO exercise. But having said that, the WHO task force that wrote the guidelines recently, they have done a very good job. They've incorporated the dexamethasone in the severely critical COVID patients. They've done a good job. So WHO is different, and the WHO task force is different. I mean, we should separate the politics from the science. The task force involved one of the best leading experts in the world, and they've done a fantastic job in sort of writing these guidelines. So I think the guidelines now are quite sort of evidence-based. There's quite robust, and it has come out in almost all the journals. It's up for individual institutions and the doctors to get acquainted and practice what is best. If you give steroids early on, it will be detrimental to the patient. Steroids have to be given later on. Remdesivir again, if you have to give early on, then it has got some benefit. So it's not only when you give, whom you give, these sort of things, doctors have to get acquainted and practice safely.
Yes, sir. Recently also, like I have seen a lawyer named M.L. Sharma, he has filed a bill in the apex court demanding the CBI investigation on these drugs actually. Like, why when these are not, proven, scientifically, I mean, why government or, government is insisting, I mean, or, why doctors are giving these, drugs to the people. I mean, even a bill was filed, sir, demanding CBI investigation.
In terms of remdesivir, there is a data just came through yesterday in the New England Journal of Medicine. It's a randomized control study, and they have shown a clear benefit of early discharge, about 4 to 5 days, as compared to the usual standard of care. So even though it didn't translate into mortality benefit, but definitely if you give early on, there is some evidence now to show that there'll be some benefit. So we're given a scenario that we don't have anything at the moment. So I think probably using remdesivir early on during the course of illness, I think it's probably is acceptable.
Okay, sir. Thank you. Also, I observed that I have seen in most of the cases in rural tier 2 or tier 1s, I mean, like tier 2 or tier 3 places, like giving high dosage of drugs like has resulted in some sort of deaths. Even I've known my I know one of my friend father, due to wrong dosages like he passed away. So there is a wrong practices regarding the dosages of medicine being given. So I think even this factor like I've seen that one of the major thing which needs to be addressed.
I mean, this polypharmacy or a cocktail pharmacy, as I call, it's not a new thing in India. I mean, people sort of treat, for example, somebody comes with a fever, treat for dengue, treat for malaria, treat for bacterial infections. That's because of the diagnostic part of it, the accuracy of the diagnostic part, and given that the patients are also too demanding, doctors often resort to this polypharmacy. I mean, I don't agree on this polypharmacy, especially in a disease like this, because if you give drugs in a wrong order, you're definitely going to do more harm. I just quoted you just now that dexamethasone, if you give in mild cases, I mean, actually the studies have shown that it is a detriment to the patient. So it has to be given later on. So I mean, this is something is a chronic problem. I'm not surprised that it is happening still.
Okay, thank you. Also, I observed like one of the another major reason is the testing kits. Like as on April 16th, India received close to 5.5 lakh rapid COVID-19 testing kits from China. It's reported by ICMR. Also, like I hear that a lot of issues. Even have consulted many people regarding the quality of these kits and results. I've seen that like for the a person being tested at different places the same the testing kits they have given the wrong results actually. And for the person who doesn't have a COVID it showed COVID, and once again when you test it again it's showing I mean, even the testing kits quality of testing kits, lack of quality in the testing kits can also be one of the reasons in the rise of COVID.
Yeah, I mean, India, because of the sheer population, so they employed the rapid antigen test as opposed to RT-PCR, even though ICMR recommendation is you should have a RT-PCR. I mean, for a rapid screening, I think still it is acceptable to go for an antigen test. And most recent papers in the last week or so has in fact supported the view, because you want to sort of pick up those cases, and when if you pick up positives on the rapid antigen test, that means they are very highly infectious, and then you can sort of clarify with the RT-PCR and then quickly get them to do whatever you want. Now, there was a concern about these rapid antigen testing kits from China supplied to Spain and Italy, and many of them they returned back. Similar noises were heard in Rajasthan and Delhi, where they started getting false positives and false negatives. There is a problem. There is an issue with this rapid antigen test. I mean, it can sort of RT-PCR is about 70% sensitive. Antigens are still lesser than that, but it is still a useful screening process so long the manufacturer is reliable and good. I'm not sure what the government got those tests and what is the utility. I have read about those reports. Now, you may remember that Delhi was a one state which heavily used this antigen test. And some time ago, I started seeing their number started coming down drastically, and there was this tweet coming through, congratulating Delhiites for the fantastic sort of victory over virus, whatnot. Suddenly it started going up, and then I realized that it is because of those antigen tests that were being used, and later on when they started using more of RT-PCR, those tests, those who missed out were getting captured. Of all the states, only 2 states I can quote were being giving this bifurcation of the antigen and RT-PCR, how much they are doing. Maharashtra is one state. They have done very well in terms of data release, and a lot to learn from what they release. And I particularly laud this particular IAS officer called Ashwini Bave. I usually watch out her tweets every day, and she gives this fantastic breakdown where you can see how many antigen tests they're using on RT-PCR, so that you can actually correlate the authenticity of the figures coming through. The other state which has done pretty reasonably well is Andhra Pradesh, which is also given the breakup of the number of tests doing. But on a large scale, most other states are using the antigen test. And therefore, question about the reliability of those pickups. Well, I mean, I've read about these reports of giving false positives to the patients and whatnot. So yeah, I mean, the problem exists there. But on a large, you cannot criticize using the rapid antigen test because we can't afford RT-PCR test. Even then, government has slashed down to 2,500 rupees. It is still a big money. Daily laborers, marginalized sections, they can't afford even 2,500 rupees. So I think going for antigen test is the right way, but I think somewhere you should have also quality control of these kits. And with this new development of these paper strips that is being developed by India, hopefully, I think if they're going to market it for 500 rupees, if it comes through, then I think probably it's going to revolutionize. That's based on the CRISPR technology, and they have got something like fantastic 96% sensitivity. If it gets through, I think probably it will solve a lot of problems. It will be a game changer.
Yes, sir. Thank you, sir. Like also, if you are, especially in India, like we have seen the percentage of people recovering is quite high compared to, like quite high, sir, recently, or like I think nearly the data I was checking out, nearly 5.9 million people, have recovered from the cases from this virus. Like despite all the, be it wrong guidelines or be it some issues regarding the medicine, vaccine, whatnot. But can you share some research finding? Like what exactly is constituting to this? Like the recovery rate in India.
I mean, recovery is a bit of a overblown and bit more hyped up figures in India. I mean, we should understand a little bit about this concept of recovery. So when you do the testing and when the person is tested positive, after 7 days of quarantine, if you're asymptomatic, many countries, they don't do it unless you're a healthcare professional, you're going back to your clinical area. So they are the ones they test, but on a large, if the fever goes away, the clinical thinking is that the virus has gone away, so they don't test. But in India, I think they do test, and the second when it comes negative or filed back to wherever the ICMR, and then in turn it goes to John Hopkins Worldometer. So that is being taken as a recovered or cured patient. So in a way, it sort of exaggerates what is occurring across the world. I mean, by rule, 99%, 98 to 99% of the world's population should recover from this virus, and we should expect only between 1 to 1.5% people dying at the end of the pandemic. So every country will have similar figures. So it's just not India alone. Every country will have similar figures of recovery. What is more important epidemiologically as well as for a public health expert is the number of new cases that are occurring every day, and in turn the daily deaths. These are the two parameters that are more important rather than the recovery rate.
Yes, sir. True. Also, like people have been speaking a lot about especially for the second time, like people who have been recovered from this issue, COVID, and like a lot of people are claiming that there are more chances that they can get infected once again, or like a lot of issues, a lot of misconceptions have been piling up, regarding this. Like, can you just brief on this? Like, what exactly is this?
So early on, the thinking was that it's impossible or near impossible to get reinfected. But then the first case was reported somewhere in Hong Kong, and subsequently a patient in America, and even in India, about 4 or 5 patients have been reported from Mumbai, the healthcare workers who got infected. So interestingly, so what has happened is some of these cases, they had a mild infection in the first time. So they didn't have enough antibody response to the first infection and subsequently got reinfected. But 1 or 2 cases I have also seen that they had equally severe infection first time and they got infected, but this time it is a different viral strain genomically when it is studied. So it is getting realized that you can get infected second time, but the numbers are lot less. Still the thinking goes that if you're infected once, you should have a reasonable protection, but getting reinfected is a possibility. Yes.
Yes, sir. Even I think that's one of the reason why I think plasma therapy, is ruled out. I think because plasma therapy also is recently ruled out by ICMR. If I feel like that, it doesn't work in all the cases.
ICMR suggested the plasma therapy to be done only in the trial setting. But what happened was there is a competition between the states to set up this plasma bank, and there is so much of publicity that is given as if it is a panacea, it is a sort of a nectar that's being given to these patients that will miraculously take you out for the jaws of the death. I mean, it is not so. I mean, we are waiting for these recovery trials or data on the plasma therapy. But what my understanding is, when somebody has developed an infection, they form all sorts of antibodies. Not only the antibodies that are specific to the virus that neutralize the virus, you also mount different types of antibodies. And some of these antibodies can be harmful in the way that they can block the mediators called as interferon. Now, interferons are the ones that are produced in our body. They are the ones who do mount the first attack on the virus. So some of these, what they have studied is about 10% of the donors will have these antibodies that actually blocks these interferon. So when you transfuse those to the patient, actually, it may cause more harm. So it is not a one size fits all type of a thing. You have to sort of see what is their antibody titer, whether those antibodies have got a viral neutralizing capacity. So many things has to be studied before you do it. But I don't think anything of those things has been sort of followed. There will be an advertisement gone, either Twitter or some other social media, that such a patient, you need a plasma. You just take some recently infected one, you take a plasma and you just send them and do it. That's not the way to do it. You need to measure it all depends on your severity. If you had a mild, it's unlikely that you would have formed a sufficient antibody titers. So I got my own reservations about this plasma therapy. But of course, we have to wait for these randomized control trial results that will be out soon. Rather than that, the monoclonal antibodies that are being developed and that is being given to President Trump last week, I think that they hold a more promise because they are more specific to the virus and they can neutralize.
Yes, sir. Even in India, I have seen many celebrities and movie stars have been endorsing this, donate plasma, like that's a Sanjeevani, to cure people and all. A lot of, drama has, happened here regarding.
I mean, remember, this drug is not drug. This treatment is a 100-year-old treatment, and initially it was first tried in diphtheria. Somewhere in Philadelphia, one of the doctor was looking after the patient, the kids in a school. What he did was he just took a serum blood of another kid who had a severe diphtheria, and then he infused, and he demonstrated that all those diphtheria got neutralized. So it's been tried all along. All infections, it's been tried. Ebola, so many infections, it's been tried. I mean, pertaining to this, whether it works, I don't know. Probably not.
Yes, sir. True, sir. Also, I have seen. I mean, most of the the initial screening, wherever you go, is only like thermal screening is being done. Like not all COVID-19 diagnosed patients, don't have a fever, temperature, but are even observing, issues like vision loss, taste loss, loss of smell sensation, and many more issues are coming. Can you please explain the nature of the virus? What exactly are symptoms of this virus?
Initially, it was thought to sort of present with cough, fever, shortness of breath. Those are the three defining characteristics as the defining criteria. But later on, as we learned more, this has got sort of expanded more to include the loss of taste and smell, and even the gastrointestinal manifestations. So it is now it's proving to be a multi-system involvement through this virus. From head to toe, practically everything can get affected. Of more concern now are the involvement of the heart and the brain. So nearly 78% of the patients who got admitted and recovered from the virus, they are known to have affected heart. They can develop the heart failure subsequently, and even it causes the inflammation of the heart muscles called myocarditis. In fact, one of those American football team, when they screened, many of them were found to have involvement of the heart, and so therefore they had to be excluded. Then onwards, people started getting, sort of screening more and more people, and we are learning now that the heart involvement is high, and probably next year we'll see many people land up in the heart failure, and that's something which we'll have to deal. The other main organ that's getting affected is the brain. This virus has got uncannily can cross across the barrier that separates brain from the blood. Very few viruses pass through this, and that is the nature's protection that has been given. So recently in Germany, they did an autopsy of about 50 patients from the nursing home who had died and who had the virus. What they have seen is about 50% of them, they had virus in the brain cells. Of course, it didn't cause much of problem to them, but it has caused problems in others. It can cause strokes in the middle-age group, particularly more common in India. I mean, there has to be more study. I'm hearing more and more people these days in the middle-age group developing vascular complications, losing eyesight, strokes, those sort of things.
Yes, sir.
And also between the brain cells, there is this connection that facilitates the transmission and talking to each other. It gets affected with this virus. So you can develop, lack of concentration, lack of sleep pattern. So we need to see whether on a long term, whether these will translate into more presentations. So already people have started talking a term called neuro-COVID. Now, you used to have this terminology used in other diseases, like sarcoid used to have neurosarcoid, connective tissue diseases and tuberculosis. But it looks like this virus is not lagging behind. It is, imprinting in every organ of the body. It is also causing involvement of the skin, kidney involvement. So it is sort of even the gastrointestinal tract. People can present with obstructions, involvement of the pancreas, and some late development of diabetes mellitus, reduced potency. So it's going to be a very myriad presentations. Once we start following them on a long term, we'll learn more and more. The one thing that's where it enters and causes maximum damage is the lungs. And already by 3 to 4 months now, we started seeing on the CT scan of these patients causing the scarring in the lungs. And some of them are oxygen dependent even today. So it's a major problem. And so significant population, if they're affected, I think it's going to affect their productivity and then maintenance, high cost maintenance of those complications. We have to accept all those things and deal.
Yes, sir. Also, I think before the world realizes these issues, I think even China, in their first wave, already reported these sort of issues. I mean, why isn't adopted in other countries? That these symptoms also can happen because of COVID.
The terminology called long COVID or long overhauls started getting realized mainly from the Italian World Cup, when they started noticing people. I mean, initially people started talking about in the social media, especially in the Facebook, where they started mentioning about this tiredness even many weeks after being recovered from this virus. Many of them were not able to go back to work. They started having shortness of breath, and then people started studying them, and they said, okay, there is a large percentage of people who are getting affected. And many of these insights came from Italy, where doctors started reporting about this involvement of the heart. So now it is a known entity called overhaulers or long COVID,
Yes.
and we have to deal with it now.
Yes, true. Also, like I was surprised, like with all technology in place, it's more than 8 months now. Like like we are unable to trace exact behavior of this virus. So can you just explain on what exactly? I mean, how exactly the behavior or signature of this virus is?
I mean, this virus belongs to. I mean, these viruses we have seen it before. I mean, because we deal with many viral infections. I used to see some reports of coronavirus in the stool or whatever. So when this first thing got reported from Wuhan, suddenly it shook me off, because this is not an unknown entity. I always used to see in some kind of reports, but that is a different one. Like there are different family of the viruses. They belong to what is called as the beta coronaviridae group, and two of the viruses have already came to this world. We don't know now, so it will be a very interesting historical aspect if somebody could go back to 1890s and see if there was any sort of epidemic that spread in this world. Then scientists what speculating is one of these similar group virus came to this world then, and now it only causes mild cold like symptoms.
Yes.
So this virus is much more potent and as well as infectious compared to the previous two coronaviruses. I mean, still we don't know. They say like it came from the bats and with some intermediate host, and then it jumped over to the human beings. So it is not mutating that much. It is a single-stranded RNA with just a very few number of nucleotides. So therefore, the mutation is very less, and all its infection is through the spike protein, that is the S protein. That is where it is latching onto the cells and entering inside, and that is also allowing it to multiply rapidly. In terms of the different viral serotypes, I mean viral types, there are about 1,200 have been described. Depending on which part of the world you're talking, there is you can divide into Southeast Asian region, you can divide the Europe and America. So they have done a very fantastic viral genealogical study in Fred Hutchinson Cancer Institute along with Massachusetts Institute. So what they have demonstrated that the American spread actually happened through the people coming from Italy or other European countries, and Italy got in turn from China, and there was a different strain that was circulating in the Southeast Asian region and the Middle East, and India got these two combinations. So there are different patterns of spread that has happened. But if you look at the viral genome of all the viral viruses that is floating around the world, they all match up to 99.5% to the original coronavirus. So it has not much change. It has still retained the same. So it's in a way good news, because we can target with a vaccine. That's where the emphasis is all about now. And it's also undergoing some change in that if there is one of these nucleotides is being replaced, it's called D614G, whatever. So that is now being demonstrated to have more infectivity, but not essentially being more killing, but just it spreads. And that's why we started seeing rapid spread May onwards in Europe and America. So these are the ones which you have learned so far.
Yes.
And also the portal of entry, you remember, is latching onto these receptors called ACE receptors. So this ACE receptor is there in practically every organ. And therefore, that is the reason it is giving an advantage for it to enter every organ it's possible. But mostly they're concentrated in the lower airways, and that's where it enters. But even the gastrointestinal tract, kidneys, and other organs, they have these receptors, and therefore they are all getting affected for the same reason.
Yes. Thank you, sir. Also, like, I mean, there is a big race, for the COVID-19 and the vaccine and drugs. Manufacturers are stating that the drug will solve the problem, but they are not revealing the safety, effectiveness, and adverse effects of it. Isn't it a big concern over the public security or public safety?
So there are about large number, I think at least I remember 800 or whatever candidate vaccines have gone into trial. So they are the different levels, phase 1, phase 2, phase 3. Just to explain what's phase 1 is done in a very, very small population. And then phase 2, you expand it, for example, 10,000. And then phase 3, when you do it in a much larger, now they're looking at 30,000. So phase 3 is the one where you will capture any issues with safety as well as the efficacy. So till so far, the Moderna vaccine and the Oxford vaccine, they've gone through phase 1 and phase 2. And before that, they have done the animal models. Now, in terms of the safety aspect, Oxford vaccine, they reported 2 cases. The one case was a transverse myelitis, that is inflammation of the spinal cord. And the second was, I don't know the details of it. And if were to be any one more case of this reported, then vaccine has to be withdrawn from the market. But they have paused it only temporarily and then resumed back in the UK, but not in America. So that was a bit of a blurred event. Nothing much was known. Very short, terse statement from the company saying that we are resuming back. What actually happened, we don't know. I hope there is no serious concern there, because if you develop something like transverse myelitis, is a very serious thing. They hadn't established any trial protocol. None of them had, and so scientists started demanding it. So then Moderna was the first one to produce this trial protocol. Then subsequently the Oxford as well as the Pfizer, they now come out and they have published their protocol. They clearly defined what is their success. But the only problem is all these 3 are using different parameters. So therefore I can't compare one against another and say this is being more efficacious than others, because they are looking at a different parameters. So that is one problem you're going to have once any of these 3 vaccines, or all 3 or more than one vaccine comes out of the phase 3 trial. When you have to choose, we're going to have a problem with this.
Yes. Thank you, sir. Also, like, I think as winter is starting, like, people have been speaking about the second wave of the COVID-19, like how it's going to be, sir, like how it's going to be.
So when this pandemic was going on, the southern hemisphere had the winter. So it was interesting to see what would happen to the influenza, but somehow it didn't spread much.
Yes.
So the behavioral scientists and the public health experts started sort of speculating that it's because of our change in the human behavior of using the mask and social distancing that perhaps the influenza was not that rapid in the southern hemisphere. But now, in the northern hemisphere, the winter is setting in fast. It's already sort of the cases are going up. I'm not talking about the influenza, but the corona cases, they're already going up. France, Spain, UK, all these countries now started having the second surge. They are all running cases anywhere from 10 to 15,000 per day. And even the deaths are slowly going up. The hospitals are getting slowly filled with COVID patients, and ICUs are getting filled. So the second surge is definitely there. It's happening. America went through first surge, second surge, and third surge now. So with the addition of the influenza flu season, it's going to be a big challenge for the Western world. In terms of, as far as India is concerned, I mean, influenza as it is not a huge problem because it is the winter is not that severe, at least in southern part of India.
Yes.
But I think probably largely it's not sort of tested and sort of screened. I still do believe that influenza will also be a problem in India along with this. But India has got another different share. It has got dengue going along simultaneously with now just with the monsoons and some mosquitoes.
Yes, sir.
So different hemispheres are having different problems. So the Western Hemisphere has to deal with the influenza and the COVID, whereas India has to deal with the dengue as well as the COVID,
Yeah.
plus or minus the influenza.
Yeah, why I'm asking is like India has like a huge influence, Western influence, even in terms of research, even medical research, a lot of influence. So I see that the practices which were followed in the Western countries are mostly adapted in our countries, sir. So that is why I see like a lot of advertisements coming in these days. Like the practices which are following in the West, are being incorporated here. So due to the demographic situation. So I felt that it may not be very apt to follow the same sort of practices which being followed in the West.
You're right. I mean, India is a very heterogeneous, very complex country, and whatever it is there in the other country, you cannot just extrapolate and say this is what I'm going to do. So I'll take you back to the paper done by ICMR in February 24th, published in the Indian Journal of Medical Research. So in the paper, they clearly mentioned that India cannot go like a lockdown of the whole country like China, because ours is an agrarian country and our economy is different. A lot many people depend on daily wages and things like that. But of course, that is not followed, and we went for a lockdown. I mean, I can't be too critical about it because that's what most of the countries did at that time. When you're dealing the Indian context, you always have to take the local experts, local public health experts who've got a long sort of track record in dealing with epidemic diseases. India successfully managed to eradicate polio, tuberculosis, good control, malaria, filariasis. So there is a good sort of backbone. So, but the only caveat is you need to take those experts into confidence and sort of give the lead role, which probably didn't happen in this COVID. That is what being expressed by many experts, that they were not heard. So instead of sort of relying an external agency or some other university to come and do studies in India and then give advice, I would rather prefer a local expert who knows the underlying deficiencies and the positives of the system to give recommendations.
True, sir. Exactly. I mean, the same thing I've been observed from many health experts. Many health experts in India have been suggesting that like not suggestions their suggestions are not being considered. And one of the reasons for the massive rise of the COVID cases in India. Also, like I have observed recently, sir, recent news is that the government has decided that the first set of vaccination this COVID is going to be given to the health workers and doctors. I don't know whether it is wise enough, or I don't know how to understand this. Like when nothing is proved, giving directly to the health experts, or the health workers. I don't know how fair it is.
So there's something called as challenge trial. So what they do is you directly challenge, you administer a vaccine and then see what happens. So some countries, I think they favor this, but more or less I don't see any country doing that as at now. So there is some growing voice that why don't we let healthcare workers, mainly because they are the ones who are getting affected daily, the one or two succumbing to these infections. Why don't we allow them to have these vaccines directly injected?
Yes, sir.
But the problem is we don't have the phase 3 data, and the Indian government initially mooted this Russian vaccine, where there were only 76 people that tried in Russia, 38 and 38, two groups. And based on that, you cannot be going and vaccinating, millions and risk the population. And rightfully, the drug controller has not given go ahead for these phase 3 trials. Unless we've got a robust data that's coming through the phase 3, we cannot jump and start vaccinating everybody, because you need to have at least minimum of 50% efficacy before you go for a vaccination. Even if it is like 30% efficacy, then it will not serve the purpose. It's like a very dynamic process. The pandemic is a very dynamic process. Your efficacy will depend on the incidence of infection in the population. So if the it's for example, if the incidence is very high and rising, you need a higher efficacy to deal with that. So all these factors have to be taken into consideration before you say a particular vaccine can be released into the market, whether it is given to the healthcare workers or some other group as a first. It's up to the government, and I think probably it's sensible to do healthcare workers and all the people, police or other people who are in the front line, because they don't have absolutely no protection. But we need to wait for this phase 3 data to come through.
Yes, sir. True. Especially I have heard a lot of cases, treated by some Ayurvedic, and homeopathy doctors, there is a lot of, people claiming, there are people actually, I myself know few doctors, Ayurvedic doctors, who told that, the COVID is as it is, it's sort of immunity system, like Ayurveda and homeopathy, they have been, largely successful, in treating this, COVID patients. Even in Maharashtra, I've seen like an Ayurvedic doctor, I've seen a lot of YouTube videos, and even in, even in Andhra and Karnataka, I've seen a lot of, Ayurvedic and homeopathic doctors telling that, this, COVID can be handled by, Ayurvedic and, homeopathy. So why hasn't, a considerable acceptance, not received from these, why Ayurveda or, homeopathy didn't take into, mainstream to handle the COVID situations?
So the main problem is in dealing with this viral infection is whether you treat it as an immune deficiency or as hyperimmune status. You have to sort of be clear on that. Now, what happens is that in the early stage, when you get this viral infection, for example, in elderly population, their immune system is weak and it cannot mount, is not mounting a response to kill the virus. Yes. And there you consider your immune deficiency, or not actually immune deficiency, but immune dysfunction. It's not working. Whereas once the virus starts replicating fast and then starts creating a problem, that's where you got the immune system being overactive. So it is not a one single spectrum. You got a different spectrum happening. Now, what in Ayurveda, what they say is we'll do the immune boosting. Now, it sounds diabolical, isn't it? You got this hyperactive immune system. Once it goes off the trajectory, if you actually try to boost the immune system, it may prove counterproductive. So therefore, anything that is given in Ayurveda or homeopathy has to be early on to prevent the virus entering or replicating it. Whether we have any drug that has proven to do it so far, well, no trial has been done. Unless you do trials or testing, you cannot claim a particular drug that can be recommended. There is a conflict in India between the Ayush Ministry and the allopathic doctors. And in fact, the Indian Medical Association called the Ayurvedic medicine as being a placebo from the government directive that is issued. Now, both sides are at loggerheads, and I saw this letter coming through by the Ayurvedic practitioners saying that you are giving the hydroxychloroquine, which is sort of totally debunked and waste drug, and you're calling our drugs as a placebo. Now, this is not a time to sort of split here who is right or who is wrong. I do believe every specialty has got a science in it. We cannot just snub away Ayurveda. It has been there for the last 5,000 years. It's just that we don't have a good sort of researchers, people who have an academic background or a research mind to test these drugs and systematically observe. Yes. I mean, one of those company they did that, coronal or whatever. I mean, the whole design was a bit of a flawed thing, and then they marketed it out, and later on they pulled it out. Now, this is a problem with this alternative medicine like Ayurveda and homeopathy. So you need to test these drugs, and I don't know why ICMR didn't take this initiative. All the while they kept sort of propagating this hydroxychloroquine. I got completely bored about all the time talking about this useless drug called hydroxychloroquine. It was time to move on and try different things. Like I'll tell you that China, they regularly test their herbal medicines, and I see them in all the scientific papers. Many of those wisdom has come from the Chinese herbal medicines, and I know for sure that some of the cancers are treated successfully by using their herbal medicines. And even in Wuhan, they use this. So why can't we set up, India has got such a vast infected population. It's very easy to just do two groups. One group you give whatever the standard treatment, other one you give the Ayurvedic product or whatever, and then you solve the problem. I mean, whether it works or not. If it works, fine, fantastic, go ahead and give it, because they don't have much side effects. The problem comes is when individual doctors, they come and tell, I gave this drug and therefore, so it worked. It's a similar story with all these hydroxychloroquine doctors.
Yes.
They're telling, I treated 500 patients and they all got better. It may be that you're selecting those population which even without doing anything, they get better. If you select that and you give it, it doesn't prove anything. So there has to be some sort of an objective evidence whether after giving this Ayurvedic or homeopathy you could neutralize the virus, and then they become virus negative through RT-PCR, correlate with the symptomatology. You can do that. It's not that you don't have a scientific minds, but unfortunately the ICMR is totally it's not very effective in sort of implementing out of the box and moving this. And also remember this allopathic doctors have always been allopathy, or the whole world of allopathy is always dominated, and some of these wisdom from other areas, other disciplines are not coming through.
Yes, I think we need to have a proper scientific setup and give enough priority and enough respect for the Ayurveda and homeopathy. At least to give them a chance to prove that this existed for 5,000 years and still you don't consider or scrap it. So I think this attitude of I think we need to revamp the complete the medical process in India. So I always feel that actually.
I call it a holistic medicine rather than calling it as an alternative medicine. I call it as a holistic medicine. If you are able to demonstrate something good in other disciplines, you can always incorporate, and then do it. I mean, traditional systems of medicines, in fact, homeopathy doesn't belong to India at all. It belongs to Germany, and they are completely, Germans, they don't touch any homeopathy, rather, it's not used in large population. They still use Western medicine. So you need to sort of prove or disprove, then it settles the matter. If it proves, fantastic, go ahead and do it. The problem comes is somebody goes to a Ayurvedic or a homeopathic doctor with these symptoms, and they keep trying this, and if it is not working, then by day 5 or day 6, when the viral replication starts happening, and then it's too late, then you've done the damage. And so that's also the problem there. So you need to take the control. You cannot give two people to fight over each other. You tell, okay, we will test this. If it works, we'll give credence to you. If it doesn't work, please listen to these allopathic doctors. So the central body has to do this.
Yes, thank you, sir. Can you make some suggestions on how government can handle this pandemic in a better way? Can you make some suggestions?
Well, this is the most difficult thing. I mean, if you look at the journey of the pandemic, how it unfolded in India from the March onwards, if you go through chronologically, then probably will understand what could have been done differently or what should be done. Now, I told about this ICMR task force, which recommended that we should not go for a lockdown, but then March 24th, India went for a lockdown. And it was one of the strictest lockdowns of all the countries, and even the world media and everybody praised how it handled during that time. And we have seen that hardly any cases were there. But whether this was the right timing of the lockdown, well, that is something which epidemiologists in India have started questioning. And I'm only quoting them. It is not my criticism. This is coming from Dr. John, Jacob John from CMC Vellore, a very well-known authority. Is one of these very seasoned and very experienced person. So what he has quoted is for a lockdown to be effective, you should put a lock when the infection is rising rapidly, and it is only a crude method to just break the cycle, and then so that you revamp your health infrastructure. So European countries and America, when it went for a lockdown, they had 10 per million or even more than 10 per million cases. And more or less, it worked for most of the European countries. If you could see the curve bending downwards after that. So Italy went first, then France, then Spain, then UK, and though UK was delayed by 2 weeks. Now, when India went for a lockdown, India had a case of about only 500 cases in the whole India and only 10 deaths. So you could argue whether that is the right time. I mean, whether we could have just waited a little bit more. I know it's easier to sort of retrospectively tell now, but for a government sitting there, I mean, if you're delayed, like how American government is getting criticized, that you delayed and therefore you caused so many deaths. So whatever available information, I think government went along with that. But now retrospectively, you know that that was not the right time, because India had only case of 0.38 cases per million, which is very low less number of cases. In fact, after the lockdown, during the lockdown, the cases started going up. Again, in April, ICMR started warning the government, saying that, look, cases are going up. Nothing was done. Again, in May, they introduced a nice flow chart when to release it, and they gave the suggestions when you can safely open up, but none of those was heeded. Of course, at the time, economic consideration was there. A lot of people were in hardship, so government had no choice. They opened it. Then we started seeing steady, steep build-up of the cases from May onwards to reach a peak in mid-September to 95,000 cases, and that's almost more than 1,000. So lockdown didn't work in India, even though contrary government figures may tell something, but we have seen that India was the only country in the world that released the lock when the cases were going up. So it was a reverse phenomenon that happened. Now, there's no clear-cut exit strategy. Now, what happened was that the central government said, instead of they being the coach of a team, they said, we'll be an umpire. You call us whenever there's a problem, we'll come and sort it out. They went to Gujarat, they went to other states, but that is now that was not the way it should have dealt with. They should have actually taken the whole leading role, because the leadership in the state levels were lacking. I mean, many of them, they had no leadership. I can severely criticize about Karnataka. I can see that they did all the diabolical things, and therefore this infection spread. So center should have taken the lead role. Similar mistake happened in America. They gave the individual powers to the individual governors. They started doing diabolical stuff. One state will allow and one other state will shut, and there's no coordination. And so that's where India also made a mistake. There is a problem that health is a state subject in India, and so therefore probably the more autonomy was given to the states. But when you promulgate epidemic act, then center becomes the superior authority. They should have actually taken the whole control. Look, this is how you do. I mean, though they have been issuing guidelines, but I don't know. They've been saying lockdown, lock release, 4, 5, 6. I mean, the whole country is open long time ago. I mean, now they're saying cinemas can be open. This is open. I mean, everybody is open. All the interstate borders are open. So that is where the infection started going up very vastly. And what happened was we forgot the basic principles of epidemiology, which we did very well in the beginning. I mean, initially, all the Western world completely forgot what is testing, what is tracing, what is quarantining, because it came suddenly. None of the countries they followed. But that was done very well. I mean, we should give credit to where India did well. India in the last from March, April, May time, this testing and quarantining was done very well. I mean, it was done by local IAS officers and local regional people, and therefore it was very successful. And suddenly, after May, it was thrown into the air, and nobody was doing it. And suddenly, they had no clue where the cases are coming up. And all the time, the focus was on foreign travelers, and they are coming from the airport, and they, it was all the emphasis was on the airport, whereas we had the local transmission happening, which nobody cared. And then
Yes,
these conflicting messages whether community transmission is happening or not. I mean, it is happening. There is so much of reluctance to say there's a community transmission happening. So when you don't apply the real-time data and the science, and if you don't take the expert advice, who are very much there in India, I'm not talking about, you don't have to listen anywhere else. India has got no dearth of fantastic people. They are there. You just have to listen to them. Unfortunately, what happened is the government relied on their own experts. Initially, what I thought, what I heard when I spoke to some of the people in the government, what they said is they're very confident in the beginning that this is something which they can deal. But slowly they realized that no, this is something is beyond the capacity by the time it is too late. So
yes,
they should have selected people who got a sound basis. Many of them have dealt many epidemics in the past. Somewhere I think probably a mistake has happened. Even now, I think they should go back to sort of regional quarantining and keep monitoring where the hotspots. Rather lockdown is not a solution at all. I mean, it is detrimental. We
yes,
can't go there. Our economy will suffer irreversibly. So at least we should follow these regional hotspots and control there. We know that nearly 50 districts, 52 in fact, districts
yes,
in India are where the main cases are coming through. So we had to sort of emphasize those particular states to bring them under control. Recently, I'm seeing the daily positivity rate is coming down to 6.8%. I hope that is a genuine figure. If it continues like that, and if it comes down less than 5%, then there is a hope that it can sort of come down. Once you reach the downward trend, then stricter measures have to be employed then, because if you lax, then there is a every possibility that second surge will happen. India is still riding on the first wave, and
yes,
whereas the other countries have moved on to the second surge. So till we get an effective vaccine, I mean, the rules of the epidemiology, test, trace, quarantine, I think still has got a role. And then they should remove this phobia from the people. COVID is made something like a leprosy. People are scared of going and getting tested. People are, doing all sorts of, cut the corner thing, like going and getting tested with a CT scan. If the CT scan shows something, then they go and get admitted and get treated, but never get a swab done, so that it nowhere in the system it gets flagged as a corona patient because of the taboo in the society and the way they live. So a lot of this government also has to do it. There is a fear. I mean, you send 10 people from your local council who keep going and torturing them, where you got the infection, who is there, where did you go. If you get 10 times in a day, when one of your relatives is in ICU, I heard number of stories. Don't make it as a stigma. That is what they have done.
yes,
They've done as a stigma. Go and then sort of planting some sheets outside the house, sealing down, locking down. I mean, what? Come on. I mean, don't do that. I mean, it doesn't work. When it is in the community, deal that it is in a community, and encourage people to go and get tested and isolate and remove the stigma. And socially, with the people movement, this can be controlled. At the moment, I see this public participation is not happening. Even the universal masking, social distancing in Indian context is extremely difficult. At least universal masking, you can impose fines, but I don't know. There will be other ways to sort of circumvent it. It is difficult, but I think we still have to stick to all these rules of the game, which we did well in the beginning, but I think we have lost it.
yes, sir. Also, like I've seen, what I've observed is in the starting the COVID situation in India, compared to then, if we observe now, Initially, we have seen our Prime Minister Narendra Modi ji, coming forward and educating people on the situation. But from past 4 or 5 months, like there has been no education or no programs being conducted to educate people on the current situation and how to behave. So I think very 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 minute, or like I would say like not even 10% of efforts are being observed, to educate people on this particular situation and how to handle it. I think there is a serious, lack of education about at this particular situation to the public, sir.
So, like whenever I go for a drive, a long distance drive, I usually listen to All India Radio. And I'm a big fan of All India Radio, and I always sort of get these advertisements regarding TB prevention or malaria prevention. There will be some public message coming through very repeatedly. And I just curious to find in 6 hours, how many messages are coming regarding Corona. I saw only one, which used to be many in the beginning. In fact,
Yes,
when I used to tune it on during, I would say May, June time, I used to get bored because every 5-10 minutes there used to be some message regarding Corona. So there seems to have some fatigue that has set in, I mean, at all levels. And because it's becoming a recurring theme, that's where the problem comes. This is the time to sort of reinvent the wheel. You need to keep on telling, even though it's boring, you please, use all the channels, all sorts of communication, and keep driving the seriousness. People don't still understand, and they think it's all gone. In fact, I'm surprised that many of the educated people, how they write, this is nothing. No, it is not. It is still there, and when it comes, it will keep killing people. So you have to keep on persevering. Education is very important. Keep using all sorts of media, and at all government levels, whether center or state. You're right. I have seen in the last 2 to 3 months, people stop talking about Corona, completely gone.
yes,
And the kind of example they are setting, I wouldn't say about the Prime Minister, because he has set a very good example by wearing mask. But other leaders, when they are seen in public appearance without mask, you have to set as an example for people who are following you. If you yourself don't set up an example, then So some of the things India has seriously failed, and it will be a huge problem because there is a reluctance to accept it. And part of it is related with the lack of education, or even in those educated COVID idiots who don't want to listen. So you got two different spectrum. You need to find a way to deal with these two. Unless people all sort of start behaving, this virus cannot be brought under control. It's very extremely difficult in Indian context. Now it is moving from cities to the rural areas.
yes,
And hopefully rural areas, because they're sparse, you may not see deaths. But bearing in mind that we don't have facilities there, it's going to be a very big problem. And our agriculture depends on the rural areas. So all efforts have to be done to break this cycle. Then again, the rural area people will come back to the cities for treatment. Again, it spreads. So it keeps
yes,
going yo-yo type of a thing.
yeah,
So yeah, I think the efforts certainly has to be prepped up. But I see that in the media and the public attention is being drawn to some other useless issues. I don't want to go into all those things. Yeah.
yes, sir. True, sir. Also, like I mean, after this pandemic came, I was a little curious. Of course, I was curious about the health infrastructure situation in India, sir. Even before pandemic, I've been doing a lot of research with respect to the health infrastructure in India. I was surprised to see that India ranks 150th in the 150th in terms of health infrastructure, and I feel that COVID-19 has truly exposed the majesty of Indian health infrastructure to the world and to ourselves, in fact. So when the country is not secured from diseases, so I think we need to rethink on how these situations.
Absolutely. I mean, in the last 60 years, I mean, how much of money has gone into the health infrastructure? I mean, GDP has been very, very low to the population, and nearly 60 to 70% of the healthcare is provided by the private healthcare, and government spending has been very minuscule, and the government setup are not geared up to deal with anything like this. So in a way, this is completely exposed. I mean, we got some good examples of indigenous ventilator manufacturers, PPE manufacturers coming through, but that's not enough. I think government has to really invest in the coming next years on the health infrastructure. At least every tier 2 and smaller towns should have a decent setup. And what we need to strengthen are the primary care, which is completely gone, missing. I mean,
Yes.
people have to sort of rely on the quacks or untrained doctors and professionals. It's a huge challenge, but I think instead of focusing only on the big cities, they have to sort of develop in the smaller towns. And once the investment goes and the infrastructure goes in, people automatically will move into those areas. I mean, if you look at many people, why they hang on to the big cities is because of aging parents who cannot access health infrastructure. So that is where I think definitely they need to do. I also would like the health ministry to be a little bit more proactive. I don't see them sort of engaging. I've been watching all across the world. There are some experts who used to come every day and update what's happening. And I didn't see that coming through from the health ministry either. You need to sort of establish some sort of a professionalism and leadership role, which is lacking evidently in this pandemic time.
Yes, sir. I mean, in a country like India, where we speak of high of democracy, so we see that there is no democratization of health infrastructure, so which is a very, very serious concern. Even in recent COVID times, if we see that after they gave permission for the private hospitals, corporate hospitals to deal with the situation. So like they charge a person nearly 13-14 lakhs for a treatment of 14 days.
Yeah, unfortunately, this is the problem. Now it is all moving to the insurance based, and our population of the people who are working who can afford insurance are very minimal. I probably 1%, 2% population. So rest of it all, they have to sort of depend on their own meager savings. And the COVID has come as a really rude shock, because average hospital admission is anywhere from 15 days to 22 days, and much longer if you are stayed in the ICU. And when I was looking at those bills that are being billed, I mean, it is astronomically high, 10 lakhs, 12 lakhs, 14 lakhs, even in the smaller towns.
Yes, sir.
And I mean, there are two arguments. One is that it is expensive because of the PPE kits and other things. But how an average Indian can afford that much? I mean, it's a gross injustice done to our citizens who can't afford. I mean, there are people who can't even afford a syringe, an injection. Yes. And then suddenly they go into the ventilator. And there are many people I've seen, husband and wife, both were in a ICU and a ventilator, separate bills going parallelly. So I think it's a very serious issue. India has to take it very seriously. I have seen a very lackadaisical approach. Nobody talks about this. And we don't debate these sort of things in election manifesto. We rather would prefer to fight over other issues, but health has never been an issue. I hope at least from now on, this is taken as a priority and something done about it. Because this is not the last pandemic. This is not the first or last pandemic we have seen in our lifetime. Many more are going to come, as scientists have been warning, and we got to be prepared. And the way it is exposed, as you rightly said, we are sort of very gross inequalities in our health system.
Yes, sir. Like when we are getting maximum GDP from GDP contribution from rural areas, instead, as they are contributing more, they have to be given more facilities than people residing in cities, in fact. But it's a reverse case here. The people who are contributing more are suffering with no facilities, especially health. I even don't worry about the rest of the facilities, but health is a basic thing, on which they are supposed to get. So even like I have seen in most of the cases, like we have some health schemes from government, like Arogyasri or something. So where once somebody gets a disease or something which cannot be cured in a government hospital, so they refer to the private hospital, and government pays to the private hospital. So instead of paying to the private hospital, why don't you equip your government hospitals? You have very big health in, very big health, setup, happening in country. We have, hospitals even in the tier 3 cities, and which are obsolete actually. So instead of paying money to the private hospitals and sending people, to private hospitals, why can't you equip the same, our government hospitals to that level? I mean, this is a common question which it's been in my mind for many years. In fact, even today, like I've known many doctors in tier 3 cities, tier 2 cities, tier 3, like they've been arguing that they are fantastic doctors. They have been offering great service, to the public, but they say that, we are not given enough facilities here, or, like compared to the private hospital. So what government does is just they refer to the private hospital instead of giving us opportunity to treat where we can actually treat.
I mean, that's a separate topic altogether. This Ayushman Bharat scheme, I mean, government has gone a little bit more gaga on this, but, if you look at the reimbursement that are given to the private hospitals, it's very less, They give something like, for 15,000, 20,000 rupees package for a major surgery. How can you manage, a hospital can manage, giving anesthetics and theater charges and those sort of things. So you cannot do this jugaad of just squeezing the private players and make them forced to do it. That's what has happened in this COVID era now. The government realized, as soon as they realized they don't have enough beds, they went into this COVID-only hospital model. I don't know who promoted that. I mean, the problem is they had all these heart surgeons and cardiologists in the panel rather than having epidemiologists, virologists in the panel. And these people had this flimsy idea that they can designate one particular hospital and everybody will go there. It was a disaster. Then started going and sort of threatening and intimidating the private hospitals. Either you accept or your license will be cancelled. This is not the time for intimidation and threatening. Of course, there is a problem in the private sector also. They have not been, they're overcharging, and we know the problem. I mean, they're not ethical, there are many problems. But, there is a problem on both sides. They have to sort of, develop a sort of public-private initiative should take place. And I hope this has given some sort of a leeway. But I have got a very great reservations about Indian health system. The problem is, unless the government comes and invests heavily, nothing was going to change much.
Yes, true. Also, considering with there are many conspiracies, about this COVID-19, as China virus and all. Like I was thinking, like, for suppose, if we consider, this as a sort of biowar or something, with rising concerns over biowars, like when the shattering economies and all. I mean, looking at the state of the health infrastructure, I think even in that, I think health should be considered under national security and, handled it properly.
Yes. See, I mean, we have a sort of a natural disaster act. There is a, for response, for example, hurricanes and, whether in Odisha or in Visakhapatnam or whatever happens, we've got a fantastic thing now. Have you heard of any sort of mass casualties in in natural disasters? Now evacuation is all happens. They're able to sort of towns and towns they can quickly do.
Yes.
So that's because of the good technology that's being employed to the satellite imagery and things like that. But somehow this health management, health sector, there's never been a sort of a national disaster response that is being set up. It may be a bomb blast or a calamities or epidemics like this now we are witnessing. I never saw sort of anything that's being done. The health has been a very neglected area, and heavy emphasis now should be given. All the countries, they've got this disaster management. Whether it was implemented or not is another issue. I mean, most of the countries, they didn't do well. But at least there is a framework. If you got your own hospitals and you know where to direct your patients, you can work along. But here is a situation where you're dependent about the private hospitals. Even the doctors themselves who are treating, they're not getting a bed, they're running around. This should not happen. I mean, there should be a framework. If this is a situation, this is activated, this is how we are going to deal with this. At least there should be more emphasis on this. If you cannot do, at least employ the private players along with that.
Yes, sir. Thank you, sir. Thanks a lot. I think I'm done with my questions, sir. Thanks a lot for sharing your understanding, your knowledge. I saw that, like, been sharing a lot of information in Facebook, right from the COVID situation, as triggered, I've been following your Facebook accounts, and I've been reading a lot of reports. That sort of, after reading all those reports, I was able to, get a bit understanding of what exactly the situation is, and even I shared with a lot of my friends. So I think, as you have been doing, I think that sort of model has to be set up by the government to promote health sector education to everyone, so this can solve our problem. So thanks a lot, sir. Thanks a lot for your interview. I mean, thanks a lot for your time and sharing all the research. Thanks a lot, sir. Thank you, sir. Good day, sir.